Right. Hello. If I ask the participants to unmute themselves and keep the videos on, you are now in the intermediate case, lower limb. Me and Joe will be asking the questions. AJ and Mohammed, who wants to go first?
I can go first, yeah.
Right, Mohammed. I'll share my screen. Tell me once you can see it, and your time will start now. Can you see it?
Okay. Yes,
All
22
right.
years.
You've got a young lady, 22 years old, Miss BH, who's a college student. She was running down the stairs when her knee buckled underneath her, and she almost fell, but she held on to the banister. She's now coming to you with pain and swelling of her right knee. You can tell me what you want to ask in the history, and I'll tell you the findings.
Okay, I would ask when this happened, and was there any pain? Did the swelling happen immediately, or it was swollen later on? Was she able to walk? And what did she do? What treatment she get it at that time?
Right. She fell on the stair, or her knee buckled underneath her 2 days ago. The knee swelled a couple of hours later, and she was able to put weight on it. She didn't actually fall to the ground, but it was just the knee giving way.
Okay. So I would also like to know that whether she had any locking, or you said that it's giving way, and did the painkillers improve the pain or not? And is
Right. What do you mean by locking?
locking, was she able to straighten the knee or
No, she's not able to put it fully straight. For
fully
the last
straight?
2 days, she's not been able to put the knee fully straight.
Fully straight. I would also like to know any allergic history, any medical problems, any medications, and what does she do?
She's a college student, and she's not allergic to any medications. She doesn't have any previous history of high blood pressure, asthma, or diabetes. No surgeries before.
Okay. I would like to examine the patient.
Right,
I
so
should,
finished with the history. Okay. This is the clinical photograph of the patient from the front, from the side, and with her sitting. Can you describe what you see on the photograph?
so this is the clinical picture which shows swelling, significant swelling of the right knee as compared to the other side. Uh, I cannot appreciate any bruising. Uh, there are there are some scar at the interior aspect of the knee joint. On one picture, she's able to flex the knee to almost 90 degree. In this picture, there is it is almost extended completely. Uh, yeah, these are my findings.
All right. So once you go on to examine her, how are you going to do that? Tell us
So
that sequentially.
So I would like to see her straight, standing straight, and I will look
She is
then.
already.
Yeah, I will look circumferentially from the behind attitude of the limb. Then I will ask her to walk if she's able to walk or not, and look at her gait. Uh,
Antalgic.
Antalgic gait. Then I will ask her to lay down on the bed, and then I will ask her to straight leg raise to check for the extensor mechanism if she's able to do it or not.
She can do that.
And she can do that. And then I will ask her to flex it as much as she can.
Any special tests you want to do?
I would like to do I would like to check the ligaments, medial and lateral ligament by varus and valgus test. For the medial ligament, I will first check at the 30-degree flexion valgus test.
That's 5 minutes.
at 0 degree, and then I will check for the varus test at 30 degree first, and then at the 0 degree. Then I would check for the ACL and PCL. I would like to check for the ACL. I will do the Lachman test.
How do you do the Lachman test? Can you describe it for me?
I will flex the knee by almost 30 degree, and I will put my left thigh underneath the thigh of the patient and do and while pressing from my left hand onto the thigh and pulling the tibia forward, and then I will do the anterior cruciate.
So would you say, what are you looking for when you're doing your Lachman test? And would you say this test is positive or negative?
This is positive.
Why do you say it's positive?
That the tibia are subluxate anteriorly with the movements.
Would that not be normal for her?
Could be. I would do the Baton examination as well.
Would you like to compare?
Yes, I would like to compare.
Right. So you've got that positive Lachman test, as you say. What further examination or what further tests would you like to do to confirm or complement your examination?
I would do the anterior cruciate, as well as I would like to do the pivot shift, but it's usually painful. I would it's more visible when the patient is anesthetized, but I would like to do the pivot shift test as well to confirm the ACL injury rupture. Right. And pivot shift test, I do the fully extended knee and internally rotate the knee joint, and then and putting a valgus stress, I will flex the knee. If there is a ACL rupture, the knee is internally rotated, and as I'm flexing, the lateral condyle pulls back due to the iliotibial tract.
Right. Okay. So yes, you're right. I wasn't able to do that test when she was fully awake, so I had to put her in theater, and this is her like pivot shift. What other tests would you like to do?
I would also check for the external and internal rotation, ACL, anterior draws test with the internally rotating and externally rotating to see the other ligaments as well, because other ligaments can also be ruptured as well. So posterior ACL with the posterior element, posteromedial and posterolateral component as well.
So what would your advice be?
For the sorry, can I understand?
What would you advise this patient? What are you thinking of?
I think this lady may have ACL rupture. She may have meniscal injury as well, because sometimes lateral meniscus is also related to it. I would like to investigate it in the form of MRI scan to confirm my diagnosis. And then
what makes you think of meniscal injury?
Is 20 to 30% are related to lateral meniscal tear as well. ACL rupture also related to that.
You mean nothing in this case which points out to meniscal injury?
Sorry?
Do you mean that there is nothing in this case which points out that meniscal injury? How can you confirm that clinically first?
We can do the Mcmary's test to confirm that, not confirming, because sometimes it can be not confirmatory, but we can do the Mcmary's test for that.
Right. This is the MRI that you requested. Can you describe the findings on this in these cuts?
So this is a T2 weighted MRI scan, which shows some increase. There's some fluid in the knee joint. It shows intact PCL on one of the view, and it shows on the medial side.
Another 5 minutes.
It I think I cannot see the meniscal shadow on the left side of the image.
Which part of the meniscus?
The body of the meniscus is not very much visible, but I think there is the meniscus is there is some shadow at the anterior and posterior aspect of the femur.
Right. So this is the next pictures going into the trochlea. Can you see anything there?
I can just see the effusion, and I'm not able to see the shadow of ACL.
Right. Does that confirm your diagnosis?
Yes.
Right. So your diagnosis so far is an ACL injury. Anything else?
ACL injury with significant effusion. And I think there is this displaced meniscus as well, but I'm not very sure about that.
Right. The X-ray report says that there's a bucket handle tear of the medial meniscus. How would you go on to manage that now?
So I will explain the findings to the lady.
Yeah. Okay.
And yeah, and this she is young, and I would tell her that the meniscus has gone inside, and we need to reduce it. Otherwise, her locking will not improve. So I will offer her a knee arthroscopy. Plus minus proceed if it is whether it is repairable or it's we may have to excise it. So we will have a shared decision. I will also explain the risk factor involved and
how
the benefit.
urgent is the operation, doctor?
So it is urgent.
Sorry, can't hear you.
It is urgent because she will not be able to flex the knee if there is a buckle handle here. And also there is a possibility that we may repair it as well.
Right. Do you want to do anything with the ACL?
I would not, because it's been shown that evidence shows that if we do the repair in early timing, it may lead to arthrogryposis. My first aim would be to sort out the meniscus and then come back later.
Okay, so we'll stop there. How do you think the this discussion went? Just one comment.
I think I moved forward and I was able to make the diagnosis. I was able to request the proper investigation and do the test. Maybe I have to be able to assess the MRI scan more better.
No, okay. Let's put it at steps. One, for history taking. Your history for this particular incident is fine, but why do you think her knee buckled underneath her when she was going down the stairs? You already identified that there was a history of giving way. Does a normal knee give way? If you were asking any further, I would have given you a history of an injury 2 months ago where she had an immediate swelling, as you said, and put on ice packs. And so since then, she has had repeated giving way. Because this ACL on the MRI does not show, that does not seem a recent injury. It's an old injury. So why is she not able to put her knee fully straight?
Because of the meniscal.
It's locked. Yeah. So the meniscus is causing the locking. In this case, this is why it is an, I wouldn't say urgent operation, but it has to be done. You never asked me what hobbies does she do or what sports does she do? She plays basketball professionally. She wants to join the national team. So we need to find the implications of the injury on the patient herself and any previous injuries. For the meniscus, you needed to identify the site of tenderness and the fact that she's locked. And these scans I've shown you are not exactly T2, they are a fat suppression. And they definitely show the locked knee with the meniscus. And you're right, you need to repair that. I wouldn't say I want to excise it in a 22 years old lady with a big chunk displaced into the trochlea. And remember that a repairable meniscal tear is an absolute indication for ACL reconstruction, because otherwise you will re-injure your meniscus later on. Thank you. I'll leave Joe to go through the next case. So
Thank
Ajay,
you very
you're
much. Yeah.
Is it me or is it Ajay?
It's Ajay.
It's Ajay.
So one case for each. You're watching your colleague.
Ajay, hi. How are you doing?
Yeah, not too bad.
Good. You're
Very
going for June, yeah?
Very slow in preparation. Anyway.
Okay, good. So you have a 6-year-old boy who came to you as a newcomer, new immigrant from mid-Asia, and his GP is asking you to examine him because he's not happy with his appearance. So tell me about what can you see. This is the child in front of you, is 6 years old. Ask me. So don't ask me, but what do you want to know from the history first?
So on the picture first, I can see.
No. History first.
Yeah,
History.
sorry.
Ajay, you're
sorry,
in the
history
intermediate
is.
phase.
I would like to know from the mom. I presume parents are present. That since
Yeah, mom is
since
there.
when? Yeah, I'll introduce myself and say hi, mom. I'm one of the orthopedic consultant. I'd like
No,
to
I'm
know.
not mom. I ask me, what do you want to ask mom?
So I'll ask, when did you notice this appearance? And,
so basically, he was slightly short once he was born, but as he grew up, he's still shorter than his colleagues in the preschool.
Okay, and I would like to know about his birth history. Was there any prenatal issue?
Prenatal issue? No, there was no any prenatal issue.
Intranatal or during birth, was there any difficulty in
no, she had a normal plan CS, and he didn't need any resuscitation or anything like that postnatal.
And any postnatal issue? You said that there was not any.
Okay.
No, okay. And I would like to ask about his developmental milestone. When did he start head holding and sitting and standing walking?
Head holding was about 4 months old. He started to sit at around 8 months. He started to stand up around 14 months, something like that. Okay. She can't actually, but it was definitely after his first birthday when he started to stand up.
Stand up, okay. And I would like to know about his language milestone as well, whether he has learned speaking as per his age.
He learned speaking quite well. He doesn't know he doesn't know lots of English, but he talks in his native language.
Okay. And any difficulty this stage in terms of, have they noticed any walking, any difficulty in walking or any abnormal walking?
Yeah, he walks funny.
Funny, okay. And does he complain any pain or any discomfort?
No, he doesn't, although he's not that of a runner and he doesn't play around with his mates quite often.
And
yeah.
And has mom noticed that any difficulty in changing his nappy or when they bathe him or change his clothes, do they find difficulty in moving his joints?
It's her first child, so she didn't have any experience with other children but basically, yeah, it was slightly difficult to change his nappies.
Nappy. And have they noticed any abnormal fold in his thigh, or like a increased crease, or no?
No,
No,
they
okay,
can't. They
okay.
don't know that.
Okay. And in the upper limb, can he move normally, or is there any restriction of any movement?
No, well, yeah, a slight limitation of range of movement, but he can do whatever he wants with his upper
And
limbs.
has mom noticed any skin, any discoloration or any spots in the skin? No.
Why do you want to ask about that?
I want to know if there is
Thank you.
any neurofibromatosis or
Okay, no,
okay.
he doesn't
No,
have any
okay.
skin
And would
discoloration.
like to know about in the any of the
Well, she
family.
didn't notice
Yeah.
it. Yeah.
Yeah, okay. And the mom, dad, anybody had any kind of deformity
Well, that
in the
concludes your history time.
yeah.
Okay. Yeah. Is that correct, Dr.
Yep.
Ahmad? Yeah.
Exactly.
So, okay. Now, tell me about your examination. What do you want to examine in this child? How would you like to examine this child as if he is in front of you?
Okay, so I would like to expose him and respecting his dignity. I would like to see from the front and the side and the back. On
What
the
can you
front,
see? This is
on
the
the
child in
yeah,
front of
I
you.
can
What can you
see
see?
he is his chest seems to be like it uh, excavatum. His the sternum seems to be a bit more in as compared to normal, and he seems to be a bit of a short stature, and his head seems to be big. And I cannot confirm on the picture whether he has got any upper limb deformity in terms of a cubitus varus or not. And its joint seems to be slightly enlarged as compared to if I look at the wrist joint on the side picture.
His wrist joint is.
Yeah, it is slightly distal radius at the level of distal radius or wrist joint. It seems to be slightly enlarged. So I would like to and I would like to check from the back side is spine whether they are aligned or not.
Is it aligned or not?
Yes, spine whether they are straight or is there any scoliotic deformity?
Well, what do you see from the side? Can you see any deformity from the
Yeah,
side?
it seems to be more lordotic lumbar spine from the side as compared to normal. And I would like to check the position of his both hips. Is there any inequality
So
on the
is his look from the front? What can you see about his shoulder levels?
shoulder level? Is left shoulder seems to be a bit lower than the right one.
Okay.
And yes,
the
please,
lower
yeah.
limbs, what do you want to know from the lower limbs?
Just want to know is the both ASIS, the patella and the medial malleolus are the same level or different level? And
well, yeah, yeah, they're the same level.
Same level, okay. Then I'd like to sit the patient and check his spine and shoulder level again, whether
Would
there
you
is
do
any.
anything before sitting the patient?
Sorry, I'll check his the walking, his gait. How is he
Okay,
walking?
so his gait, he's swinging right and left.
Swinging right and left. Okay, so I'm suspecting that possibly it's I would like to check proceed and do the Trendlenburg test if he can understand, to stand on the one leg and check his pelvis ASIS from the front or the buttocks level from the back side, and check.
So sorry, how would you do Trendlenburg test to a 6-year-old child?
So 6 year, if he can understand, I ask him to.
Well, he can understand, yes,
yeah,
but how would you do it?
Okay, I'll demonstrate him first. Say that can you stand on the one leg? I'll support his both hand to check the
Will he
pressure.
be standing on the floor?
Yeah, means either on the floor, I can kneel down, or I can stand him on the couch so that we are on the same level. I can stand and support him from falling.
Okay.
And then check the simultaneously on the left side and then right side to see which side is positive or which side I'm like, for example, if he's standing on the left side, whether
Okay,
he's.
what would you expect?
So to as he's swinging gait on the both side, I'm suspecting possibly the both side is Trendlenburg test is positive.
Okay. So
So
how would you demonstrate to the 6-year-old child the Trendlenburg test while you are kneeling on the floor?
So I'll kneel on the floor and support his both hands.
Okay.
To make to give him a confidence that he can stand on the one leg.
Okay. And then how would you demonstrate to him?
Since I have exposed him, respecting his dignity, I'll keep my both eyes on his ASIS from the front and check whether the pelvis is dropping or not.
Yes, I know, but how would you? Okay, tell me, I'm the 6-year-old boy. Tell me the instructions.
Okay, so can you I'll show you how to stand. Can you do this for me?
But
I'll
you're
stand
kneeling in front of me, yeah?
Yeah, no, I'll
How would you
demonstrate
show
him
me?
first.
Okay.
I think
Okay,
probably I'll
Ajay,
take him on the couch.
That concludes your examination. Can we go to investigations? What investigations do you want?
So I would like to get a whole spine AP and lateral view, and also his pelvis X-ray. So this is the AP of the spine, which shows there's a right-sided, it's a double curve right-sided thoracolumbar scoliosis, and
double curved. So where is the second curve?
It seems to be very subtle lumbar curve and quite prominent.
So is it a double curved or a compensatory lumbar curve?
I think it's probably a compensatory curve.
What type of curve is this? What is your classification? What classification are you describing here?
It's the King's classification.
King's.
Yes, King's classification. It's a thoracolumbar or lumbar or
I thought there is no King's in America. He was an American guy. What is he called? That's fine. What are the types? Because you say the double curve.
Yeah, so it's either single thoracic curve or the double curve thoracolumbar curve.
Okay. What type? What was he describing? Was he describing what type of scoliosis here? Was he describing any scoliosis or a specific type of scoliosis?
He's got a right-sided lower thoracic.
No. What are the types of scoliosis in general?
It's structural or non-structural. Like it's a neuromuscular issue.
So what type of scoliosis is that? Is this an adolescent type of scoliosis, idiopathic scoliosis, or a congenital scoliosis, or a syndromic scoliosis?
It's early onset. There are different types: early onset, adolescent, or then neuromuscular. So I think it's early onset scoliosis. And
what do you mean by early onset scoliosis?
And congenital as well. So no, it seems to be
2 minutes left.
Okay, thank you very much, Ajay. I will stop here. Okay, calm down, take a deep breath. Okay, let's start by the history. Okay, so when you start with the history with a pediatric, I'm asking this question. I know this is a tough case. Okay, but lately, especially in the last exam, they have incorporated loads of pediatric cases in it, and more complicated than this straightforward case, actually. Okay, so first, in the history, you asked about the short stature. Yeah, that's good. Developmental milestones, good. Prenatal, natal, and postnatal, that's good. You didn't ask me anything about the family history, all right, which is so much important in this case. Okay, you didn't ask me, is there any associated problems, like problems with vision, problems with hearing? Why am I asking these? Because this is collagen. What's your diagnosis now after seeing all these things?
Both hips, they are not developed properly. It may be spinal-epiphyseal dysplasia.
Yes. So what is spinal epiphyseal dysplasia? What type of collagen is affected?
It's a type 1, I think. Yeah.
Type 2.
Type 2. Yeah. Type 2. Sorry.
Okay, type 2. So type 2, it affects the epiphysis and affects the connective tissue, mainly in the retina and in the cochlea. So they have hearing loss and visual deficit. Okay, so these should be asked. All right. Okay, you quite ask about skin skin discoloration to exclude other, you know, other problems, but you were like, you know, you were haphazard. You were asking me questions. You know, you didn't have a quite specific and systematic questionnaire for the history of a pediatric dysplasia condition. Then on examination, you told me about short stature, but you didn't tell me, is it proportionate? Is it disproportionate? Okay. You didn't tell me, is it, you know, mainly in the proximal, in the middle, or in the distal segments? And then you didn't tell me, actually, I had to prompt you to ask you whether or not the shoulder levels are in the same level. I had to prompt you to tell me about the lumbar lordosis. Okay. And then when you were more concentrated on limb length discrepancy rather than the gait, which is so much important in these cases. Okay, I had to ask you, what will you do before sitting the patient down? Okay, and then Trendlenburg in the 6-year-old is, I don't know, my personal thing. It's very difficult. I can't illustrate it to a 6-year-old. He can't be like this. Okay, you can try, okay, but not in the, you know, in the heat of the exam and these things. And you have to stand him on a high thing, and you hold both hands, and to be able to demonstrate it in front of, I don't know, personally, I didn't do it before.
No.
You know, like, yeah, okay. So, and then examine him, examine the spine, you know, mobility, you didn't examine the spine movement, hip range of movement, limb length discrepancy. Okay, he can be short in both limbs, which is this case, but above the trochanteric area. So Brine's triangle, all these things has to come up in the examination. You're dealing with an SED, yeah? And then in the x-rays, yeah, this is an x-ray. It's called Linky Classification. And why did I ask you about that? Because you straight away, this is a double curve thoracolumbar scoliosis. Wow. All right. Okay. Even the spine surgeons would be like, you know, a little bit shaky before hitting, you know, a Linky Classification terminology straight away. Okay. I'm not saying that it might be good, bad, but come on, this is syndromic type of scoliosis. Linky was describing other adolescent type of scoliosis. This is not, okay. You can say that there is a right-sided thoracic curve with a small lumbar curve, you know, left side is a compensatory lumbar curve. You can start describing rather than going into the classification, which is not applied to congenital scoliosis. All right, okay. So, or not a syndromic type of scoliosis. Then we didn't go into management actually. Okay, this is an eye opener. Okay, go review all the dysplasia. All right, this I had the same case in one of the courses. Okay,
it's always difficult with the first station, so
yes,
don't feel